Oops, sorry about that. Hi, everybody. My name is Taylor, and today we are going to be talking about our patient. So, basically, where we're going to start is the roles of a clinical exercise physiologist. So, the main role that we're doing, the scope and the roles, is that we conduct health risk appraisals, we do exercise testing, and we interpret the patient's medical records. We help perform exercise testing while we are monitoring on the ECG, as well as picking which exercise test is best fit for the patient and their safety. We develop individualized programs for these patients to follow and testing, and all the prescriptions that come with it. And then we monitor their responses, their vitals, their health, all that. We also collaborate with other professional healthcare workers, like whether it be a cardiologist or a physical therapist. So, applications to our patient's case is we are going to analyze the um, medical records for risk stratification. We're going to identify any contradictions that they might have and determine which appropriate protocols we are going to go. And of course, develop safe, effective recommendations. Alrighty, so some expectations that we have as clinical exercise physiologists is following the ACSM guidelines for all testing and prescriptions. We're going to utilize evidence-based decision making and modify testing if they have any injuries or fears or concerns or anything that contradicts with the testing that we are performing. And then, of course, just maintain patient safety. That safety is our main concern and priority. And we use clinical judgment. And so, some things that we might do is we might modify testing, like if they're on beta blockers, that is heart rate blunting. So, we're going to monitor and change things when needed. Or if they have orthopedic limitations like osteoarthritis. So, our patient has knee osteoarthritis, so there are some changes that might be made. And then, of course, like I said, patient safety is our highest priority. So, we're going to use our clinical judgment with any comorbidities or medications that they might be on. Alrighty, so our case overview. Patient 0147 is a 58-year-old male. His BMI is 33.3, which is obesity class 1. He is a sedentary occupation. He's working at a desk in a cubicle. He is a former smoker, about 20 packs a year, but he did quit 2 years ago. And he does have a low physical activity, so he does about 10 minutes of walking. And so the reason why he's with us today is because of his post cardiac rehab evaluation. He was sent over to us, and because of his symptom limited exercise test, which was ECG monitored. So, some medical history of our patient. He has shortness of breath with moderate excursion. He does have knee pain, and that limits his mobility because of his osteoarthritis. And he does have a fear of exertion with exercise or overexerting himself post MI. He had a CAD with an NSTEMI, which is coronary artery disease, and that was paired with the non-ST segment elevation of a myocardial infarction about 6 months ago. He has hypertension. He has type 2 diabetes, dyslipidemia, and knee osteoarthritis. Let's see. So, some of his vitals, labs, and diagnostics. So, as I listed all here, we can read them all. So, I'm just going to go over it briefly. Heart rate of 62, which is a little low. He has a BP of 138 over 84, which is classified as the hypertension, and SpO2 of 97%. His hemoglobin A1C test is 7.6%, which is elevated. His LDLs are 92. His HDLs are 38, which is low. And his triglycerides is 210 milligrams per deciliter, which is high. And then his diagnosis, his left ventricle ejection is about 45 to 50% with mild LV hypertrophy, and then the grade 1 diastolic dysfunction. So, medications and exercise implications. So, the metoprolol that he is on blunts his heart rate. It is a beta blocker, so we want to use RPE instead when we are doing the exercise testing. The lisinopril monitors we want to monitor his BP because it's an ACE inhibitor, which may cause hypotension. His statin is an atorvastatin, so we want to monitor muscle symptoms. And then he's on antiplatelets, so this could increase risk of bleeding. And then the diabetes medication, we want to make sure he's hydrated and that his glucose levels don't drop too low or too high. Exercise and lifestyle status. So like I mentioned earlier, he's currently only walking about 10 to 15 minutes at a time, about 3 times a week. He does no resistance training and he does avoid hills due to his knee osteoarthritis. So his goals that we've talked about is getting up to about 30 to 45 minutes of walking continuously without breaks, and we want to try to get that up until to 5 days a week. He wants to lose about 20 to 30 pounds to get out of that class 1 obesity level. And he wants to return to hiking. That's something that we want to consider when we are programming, is taking in the patient's interest and what they want to do, not just for their health, but for their enjoyment and their joy as well. So he wants to return to hiking. Some things that we might come across is the fear of post-MI. He's kind of nervous about overexerting himself and causing any further injuries or creating new injuries. He does have a work schedule that fluctuates a lot, so he doesn't really have a set schedule. He's working mornings, he's working nights, he's on 3 days, off 4 days, or vice versa. Very fluctuated work schedule that causes inconsistency in exercising. And then his knee pain, he has a lot of hard time going up hills, down hills, just causing him to have limitations when exercising and wanting to exercise. So how is this relevant to our clinical exercise physiology practice? So high cardiovascular risk and deconditioned with reduced functional capacity. So his exercise tolerance is pretty low, which is why he's coming to us, because he doesn't have that consistency or that exercise tolerance to start. And so that's what we're here to help him with. So I think that this patient requires ECG monitoring. He might have some modified protocols because of his knee and because of his fear. And then I want to use his RPE-based intensity for how he's feeling when we are doing the exercise test because of the medication that he's on. And then his exercise tolerance, safe monitoring, and progression rate are some things that might be impacted due to his current health. So our contradictions analysis, so some absolute contradictions that he has which are not present, is stable angina, no uncontrolled arrhythmias, and no acute MI less than 2 days. For relative contradictions which are present, moderate hypertension history, like we mentioned with his blood pressure, his reduced left ventricle ejection, his diabetes that he doesn't really have under control, which I never mentioned, but he is on like a high sodium processed easy access food with his work schedule. He just brings things that he can warm up, so it's not always the best. And his lack of current exercise, and his orthopedic limitation with his knee OA. Clinical decisions. So for our patient, I recommend that he can perform exercise testing, although I do want to make sure that it is symptom limited and ECG monitored, as well as being medical supervision is recommended, just in case anything happens, in case he's not feeling well. He does have a couple things going for him, like with his MI, his stent, his diabetes, hypertension. We just really want to be there so that we can monitor him and make sure no further injuries occur while we're doing this. And like mentioned, I want to use the RPE scale because of the medication that might change his vitals to come off as not normal of what we would see during an exercise test. I want to use the cycle ergometer because this is a stationary, low impact, might be better for his knees and for his health and for his fear. And then gradually increasing the workload. I want the progression to be slow and gradual so that it is achievable, it feels good, and he's not scaring himself with like possible injuries like on a treadmill or walking up hills, and like I don't want him to be in any pain with his knee or any of that. Alrighty, so professional and ethical considerations. So for HIPAA, we obviously want to protect the patient confidentiality. We don't want to be sharing his information where we shouldn't be. Just making sure that he feels trusted within us. And what else we want to do is have informed consent, because this way the patient knows what we're going to be doing, how we're going to be doing it, explains all the risks and benefits of testing, and we're just making sure the patient's fully aware of what we are doing and why we are doing it. We also want to maintain a safe clinical testing environment and make sure that emergency preparedness is required so that we're in the right facility with the right equipment. Again, making sure everything is following all the rules and all the lines. Alrighty, ACM Code of Ethics. We want to act in the patient's best interest. We want to use evidence-based practice so that everything are following the guidelines and we know we're giving the best care that we can give. And maintain professional competence. We don't want to go in there not ready. We don't want to make the patient more stressed or nervous about any testing, because we're here, we're ready, we're educated, and we know what we're doing. We want to educate the patients because he did mention fear. We want to let him know what we're doing, why we're doing it, how it's going to help him, what we're going to see, what we're not going to see. We just want to make sure the patients are educated so that they're with us, they're ready, and they're going to give their all. We obviously want to promote safe participation for us, for the patients, keep them safe. It's our number one priority. And ensure accurate documentation. We'll get the signatures, we'll make sure that all the tests we're running are correct, we'll make sure the vitals are correct, we'll make sure all of our paperwork is signed and that the patients are good to go, as well as for us. So, our professionalism reflections. So, accurate EMR interpretation is critical, because if we're reading the medical records wrong, we could provide the wrong test, we could provide the wrong data, the wrong prescriptions, programming, all of this. We need to make sure that everything we have is accurate so we can properly make decisions and move forward from there. Like, this kind of goes hand in hand, clear documentation, because if we're aware of what we're doing, how we're doing it, and it's right, and we share this information with the patient, they're going to feel comfortable with proceeding with us and making sure all of their care is continued and properly continued. Communication builds patient confidence. Yes, because if they are fully aware that we're here to help them, we're here to get them on board, we know what we're doing, and we want to help him get to where he wants to be, that is going to build confidence, that's going to build trust, and he's going to go so much further if he knows that he can rely on us to help him reach the goals that he wants to get. And then, as clinical exercise physiologists, we play a key role in bridging his exercise testing, his rehab, his programming, into being independent. We want to have him feeling confident moving out of this so that he can perform daily exercise consistently, safely, with the confidence. We don't want to leave him feeling confused or feeling worse. We want to just make sure that he's getting into that life where he can go hiking, he can be independent, he can take in the groceries, walk up the stairs, doing everything he does on a daily basis at an easier level for him. So, is our patient ready for testing? Yes. Again, I want it to be monitored with an ECG and with medical staff. Like the monitoring level, we want to make sure his BP, his blood pressure, and his heart rate and all the symptoms are tracking. We'll get his symptoms before the test, how he's been feeling that week, that day, his symptoms during, and his symptoms after, as well as all the vitals. And as mentioned previously multiple times, the RPE-based intensity, because of the fluctuations or possible different readings of the vitals due to medication. And as clinical exercise physiologists, we just want to ensure a safe, individualized, evidence-based exercise test by integrating all the data from the ACSM guidelines and any patient limitations, and just making sure we're there for our patient from start to finish. And these are some of the references that I use, and it was really nice talking to you guys today. Thank you so much.